Hi, I'm Steve Selig, the founder of FitTest, and I'm going to produce a five-part series on the excellent um, European Society of Cardiology guidelines on sports cardiology, but particularly on exercise for patients with cardiovascular disease. In the first part of the five-part series, I'm going to just talk about some background that will help you to better use the new guidelines. I'm going to cover the exercise paradox, pre-participation screening, pre-participation exercise assessments, coronary artery disease, and also obesity, hypertension, in other words, cardiometabolic disease. The guidelines, the European Society of Cardiology guidelines, are freely available to all, and I strongly recommend that you access these. Very easy to find. Everything is free in those links that I've screenshotted below, so you can get the full text. The full text is an extensive piece of work. It is 80 pages. And it is covering a large number of cardiovascular and cardiometabolic morbidities. And there is also some pocket guidelines. And as you'll see as we get to the end of the series, within those summarized guidelines, they're of what they've described as the 10 commandments of exercise for patients with cardiovascular disease, which really captures the major summary of the guidelines. I've gone through the full text. I strongly recommend you download the full text because it does have a lot of minute level information, which is extremely valuable. I'm not able to produce videos down to that level of detail because we'd be here forever. However, you can certainly access the full text and then use it as a reference material, but also the pocket guidelines. Interestingly, there is also a slide set, which I've just indicated at the bottom. Now, the way that they've structured the framework for the recommendations, first of all, the classes of recommendations, where there is evidence or general agreement among an expert audience that a given treatment, procedure, or intervention is beneficial, useful, and/or effective, then class 1 means that it is recommended or is indicated. Class 2 is split into class 2A and class 2B. This is where there's some conflict in the evidence, lack of consensus in the evidence, divergence of opinion about the useful and efficacy of a treatment, procedure, or intervention. Now, if the weight of evidence or consensus is more in favor of usefulness and efficacy, then that's class 2A, and the intervention should be considered. Class 2B, the usefulness efficacy is less well established, there's less consensus, there's more difference of opinion on the efficacy and usefulness and benefit. And then we class 2B, the guidelines have classified this as may be considered. And then if the general agreement or the consensus is that the given treatment or procedure is not useful or effective, so that might be a placebo effect, which you could argue is still effective, but more than that, in some cases may actually be harmful. And then in class 3, it's not recommended. Then they look at the levels of evidence, and I'm sure a lot of you viewers who are looking at this video will be familiar with this kind of table. So A-level evidence is where the data is derived from multiple randomized clinical trials or meta-analyses where these trials are brought together into a single data set. The level B evidence is where data is derived from a single randomized clinical trial. So there's no other evidence independently backing that up, or large non-randomized studies such as observational studies, but they need to be large. And then level C evidence is really relying on the consensus of opinion of experts, or there might be small studies that are sort of pointing towards an evidence base for this, but really needs the randomized clinical trials. So first of all, the exercise paradox and sudden cardiac death, which I'm sure you're familiar with. In the technology age, which we are now living in the 21st century, it is more important than ever to get enough health-promoting physical activity and exercise. However, there is an exercise paradox. Again, many of you are familiar. There is a small increased risk of sudden cardiac arrest or sudden cardiac death, SCA, SCD, during exercise itself for individuals with either overt or covert cardiovascular disease or cardiometabolic disease. But this doesn't argue against the application of exercise for these individuals. In fact, the opposite, because for the rest of the day, they are at markedly reduced risk. So if you take the whole 24-hour period for someone with overt or covert cardiovascular disease who is exercising, small increase in risk when they are, but markedly reduced risk for the rest of the day. That's the exercise paradox. Sudden cardiac death in young athletes, fortunately, is infinitesimally small, but it's caused by a variety of structural and electrical disorders of the heart, including cardiomyopathies, and I'm sure you are well aware of hypertrophic cardiomyopathies in this, ion channel disorders such as Brugada, other conduction disorders, coronary artery anomalies, that is where the coronary artery traverses in relation to the heart muscle itself, the coronary arteries, sorry, and we're talking about epicardial arteries here, and also, interestingly, acquired cardiac conditions in young athletes. In older individuals, underlying acquired cardiovascular disease is the most likely cause of sudden cardiac arrest or death. Mostly from acute myocardial ischemia from atherosclerotic plaque disruption or thrombosis, and these can lead to arrhythmias, of course. But in long-term endurance athletes, sudden cardiac death and myocardial ischemia can also occur from so-called demand ischemia due to an imbalance between oxygen supply and demand, resulting from stable calcified plaque and fixed stenoses. Now, those of you who have attended any of my workshops will understand that this is a fundamental way of thinking about cardiovascular disease that I bring to all of my workshops. So that point 4B is very important, as is 4A. So either of these can lead to sudden cardiac arrest in the form of a lethal arrhythmia. Now, in terms of pre-participation screening, first of all, I've produced a YouTube video on this very topic, which I'm not going to go to now, but I've given you the YouTube address there. You can search for me, Steve Selig, on YouTube, and you'll find a lot of these videos, and I recommend you do that. And those videos are free. So we now, together with some very senior practicing colleagues of mine who are both practitioners and academics, we have produced a pre-screening model, and it's based on clinical reasoning. And so the main model is this pathway here from GP or specialist through accredited exercise physiologist using a clinical reasoning and assessment regime. You might want to use published questionnaires. I don't need to use these. I prefer to take my own clinical reasoning path, working out whether there are any adverse signs or symptoms. If there are not, we can proceed to exercise. If there are, we need to loop back to the referrer and get things sorted out before we engage in the loop again. And eventually, hopefully, you come through to that green bar. The client is safe to commence or continue exercise. However, you still need sign and symptom vigilance. And if these appear at some point in the future, again, they need to be referred back. So that's all published, and this is a freely available article in Sports Medicine 2018. So I recommend you get that. It's freely available. Now, as pre-participation exercise assessments, you will be well aware that I'm a big fan of these as well. And I've written a lot on this, and I have obviously produced a lot of YouTube videos on this. And my app Fit Test is very much geared towards this sort of approach. So in adults and elderly individuals, especially those naive to moderate to vigorous physical activity or exercise, exercise testing or cardiopulmonary exercise testing or similar is a useful means to assess overall cardiovascular health and performance, And then once you've done your exercise testing, exercise assessment, you can then produce individualized exercise plans that you've got a high level of confidence are going to be safe. Exercise assessments are also useful more broadly to detect or record previously unreported adverse signs or symptoms that may be clinically significant. This is a really recognized benefit of doing your assessments at the beginning of your relationship with your client, with your new client who may have overt or covert cardiovascular disease. This is just so important, this point too, because you can exercise your client up to the level of intensity for which you want to prescribe exercise, hopefully just a little bit above that. And then if there are any unreported or previously unreported adverse signs or symptoms, you can send those back in the form of a referral back to the general practitioner or other health professional. And then from that, in the case of the GP, who can then recommend that a cardiologist is a referral to a cardiologist, who may then recommend some kind of stress imaging test that can further investigate the adverse signs or symptoms that may be clinically significant. This is an incredibly important part of the exercise professional's role with clients with cardiovascular disease. Pre-participation exercise ECG testing, which we can do now with fairly simple technologies as they're coming online. However, they should be reserved for more symptomatic individuals, including some athletes, or those deemed to be at high risk of adverse events, adverse signs or symptoms triggered by exercise. Now, the reason why we're reserving ECG for these sort of individuals is that exercise ECG on its own has relatively poor sensitivity and specificity for diagnosing coronary artery disease. But on the other hand, it is very useful for detecting exercise-induced arrhythmias and conduction defects. Now, pre-participation exercise planning comes out of the assessments, but I'll just add a couple of points. The use of predictive equations for heart rate peak and the use of heart rate range or percentage of heart rate peak for prescribing exercise is not recommended for many individuals with cardiovascular disease. And I'm sure you all understand the primary, example of that are beta blockers. Better to use percent of VO2 peak or ratings of perceived exertion to prescribe exercise. Now, in this series of my take on the European Society of Cardiology guidelines, I'm not going to be here providing recipes for exercise prescription. You are all exercise professionals. You take the information that the client provides to you in various forms, whether it be a referral or whether it be face-to-face interactions with your client, and you will then determine from that what is the best exercise prescription, and hopefully that includes a pre-participation exercise test of some kind, of which fit test is ideal from the point of view of aerobic exercise prescription. Now, coming to apparently healthy, what to do. I'm sure all of you are very familiar with the sentence underlined in red. So the general recommendations, these have been widely published for many years, at least 150 minutes per week of moderate intensity or 75 minutes per week of vigorous intensity aerobic exercise or equivalent for all apparently healthy adults. Regular assessment and counselling to promote adherence, multiple sessions of exercise spread through the week, and also not written here, but I'm sure you're well aware, other modes of exercise, particularly resistance exercise or strength training, should be included as well 2 or 3 times per week. For cardiometabolic conditions, including obesity, hypertension, dyslipidemias, and diabetes, in obese individuals defined as BMI more than 30 kilogram metre squared, or waist circumference more than 80 for females or more than 94 for males. Resistance training should be added at least 3 times per week, in addition to moderate or vigorous aerobic exercise, of which that will be 5 to 7 days a week of at least 30 minutes. And that's also recommended, that resistance training is recommended for further reduction in cardiovascular risk. And you'll notice on the right here, we've got level 1 recommendation and level A strength of evidence. So this page here, this slide here is showing on the whole strong recommendations in favour of, and in most cases either an A or a B level of scientific evidence supporting that. The bottom one there, in individuals with uncontrolled hypertension, that is systolic blood pressure more than 160, high intensity exercise is not recommended until blood pressure has been controlled. However, this is a low level recommendation, and I know some of you would be going potentially not going in against this, and level C evidence. So it's really just an expert opinion that this is not recommended. That is level 3, not recommended, but the evidence is quite weak. Now, in my case, I do work very hard to try and get people with uncontrolled hypertension, that is systolic, for example, more than 160. I haven't got diastolic here. We really want to get in better control of this by working with the medical practitioners as well before we go on. But I've also written and produced YouTube videos on this topic, and post-exercise hypotension has a real application here for people with uncontrolled hypertension. I recommend you follow up some of my articles and YouTube videos on this topic. So for aging, among adults aged 65 years or older who are fit and have no health conditions, then you can just take the general guideline. At older adults at risk of fall, strength training should be used as well. And the recommendations for individuals with long-standing chronic coronary syndrome. And again, you can look at the class of evidence and the level of evidence, the class of recommendations, sorry, and the level of evidence. Risk stratification for exercise-induced adverse events is recommended in individuals with established chronic coronary syndrome prior to engaging in exercise. Now, we in Australia, as exercise physiologists, can do this risk stratification ourselves without referring to any other health professional because of the nature of our accreditation scheme. And I strongly recommend that you do that either using some kind of questionnaire, but preferably you based on clinical reasoning, which is the method that I use. Down the bottom there in the red underline, leisure time exercise below the angina and ischemic thresholds may be considered in individuals at high risk of exercise-induced events, including those with persisting ischemia. So how can you prescribe exercise below the angina and ischemic thresholds if you don't know what those thresholds are? So again, it's very important to establish those thresholds, or at least establish a very good range of exercise intensities that you can definitely infer, if not prove, are below those thresholds. And that will certainly be equally as good. Now, my app fit test does that beautifully. Competitive sports are not recommended in individuals at high risk of exercise-induced adverse events or those with residual ischemia, with the exception of individually recommended skill sports. Also, coronary artery calcium is becoming increasingly prognostically useful. Now, after acute coronary syndrome, which some of you may just think of as a heart attack, if you like, exercise-based cardiac rehabilitation is recommended in all individuals with coronary artery disease to reduce cardiac mortality and rehospitalisation. Again, I have written extensively on this topic and produced YouTube videos on this topic. Now, what about microvascular disease? In other words, diffuse coronary artery disease. Again, I've produced a YouTube video on this topic and I've given you the address there. But you can search for that topic on YouTube. Stress CMR, cardiac magnetic resonance imaging, and PET, positron emission tomography. In other words, these more sophisticated imaging techniques can detect abnormal coronary flow reserve, which is really often about microvascular disease. and this can lead to indicating coronary microvascular dysfunction and disease with either critical or non-critical lesions, but the non-critical are obviously very eligible for exercise. There are no well-established treatments yet for microvascular angina, but some technologies are emerging. For example, shockwave lithotripsy, and I have produced, that is in that video that I've just referred to above. However, the panel suggests adhering to the same exercise recommendations for microvascular disease or diffuse coronary artery disease as it has for long-standing chronic coronary syndrome. Now, the references that I'm basing all 5 of these short videos on are shown here. So these are your references, and you'll notice the very first one there by Sharma and colleagues is on the 10 commandments for the guidelines. So thanks for watching this YouTube video. And as you know, Fit Test is best viewed on a laptop or tablet. The address is at the top there. You can also contact me directly at info@myfittest.com.au. Thanks for watching this video, and please, as the other parts of this series come out, have a look at those as well. Bye for now.